The prevalence of comorbid disorders with the eating disorders, we know that comorbidity tends to be the rule rather than the exception. There's been a fair amount of work done on this topic for many years now. Very clearly, anxiety disorders are very, very common in eating disorders, probably the most common co-occurring disorders or group of disorders. And especially they are known to predate the onset of both anorexia nervosa, bulimia nervosa, and binge eating disorder. There are also other groups of disorders that are highly comorbid with the eating disorders, in particular mood disorders, particularly major depression, but also substance use disorders of a variety of kinds. There's recent evidence that attention deficit hyperactivity disorder is also highly comorbid with eating disorders in general. There's a lot more research kind of ongoing about that right now. In terms of food addiction, that's again not something that's accepted into the diagnostic and statistical nomenclature. It's a rather new condition, although the available information that we have about those people who meet the Yale or who score high on the Yale food addiction scale indicate that they have a significant amount of comorbidity. They tend to have higher eating disorder psychopathology, meaning more severe symptoms compared to those without food addiction. They also have higher rates of mood and anxiety disorders. More recent data shows that they have higher rates of trauma and post-traumatic stress disorder as well. It's very important to do a complete assessment of patients with eating disorders. As I said, comorbidity tends to be rather the rule, and so you have to factor in all of the different problems in order to develop a reasonable and effective treatment plan. One of my interests has been the role of trauma and post-traumatic stress disorder in eating disorders. You also have to factor in substance use disorders, depression, and so on. It kind of depends on what is the most life-threatening in terms of where you focus. If you've got someone who is severely underweight, you're not going to worry so much about the trauma issue. You're going to need to refeed them. Generally, for many years, we've known that nutritional rehabilitation is really necessary place to start with pretty much all eating disorders. You have to attend to the weight deficits in the case of anorexia or the abnormal behaviors as in the case of bulimia, and then move into the underlying issues and the intensive psychotherapy, so to speak, followed by a maintenance phase. So you have to kind of prioritize your focus based on the lethality of the problem, the immediacy of it, the level of care. Generally, the recovery from an eating disorder takes months to years. It's a lot longer than what most people realize. We know that patients can very much recover. That's the good news. The bad news is that it takes an awfully long time. Probably, there are so many different questionnaires, and you certainly can't administer them all. But I think most people agree that doing some sort of a structured interview using the DSM-4 criteria, and most notably the structured clinical interview for DSM-4, and now it will be for DSM-5, although that's not out yet. But it's a structured way to go through all of the major groups of diagnoses. And you can modify it based on what you think are the most likely and based on the family history and the personal history. Most people use some form of the eating disorder examination, whether it's the direct interview form or the questionnaire, which is a self-report. Self-reports are obviously a lot easier to administer and score than or interviewer-rated measures. But many people use things like the Beck Depression Inventory or the Beck Anxiety Inventory or the Y-Box, which is the Yale-Brown Obsessive Compulsive Scale, and there's one that's modified for eating disorder-related obsessive compulsive symptoms. There are PTSD symptom scales. Generally, people start off with a kind of comprehensive clinical interview, and then if they're not sure about a particular diagnosis that they may suspect, then they may then administer more structured interviews. Often, for example, if people think that there is an element of an autistic spectrum disorder, then one may need to administer structured scales to look at Asperger's disorder or other autistic spectrum disorder, affective spectrum disorders, autism. You will be editing this, right?
Yes.
Autism spectrum disorders, yes. Yeah. I think part of that is just better research that has identified the presence of eating disorders in men at rates that are much higher than what we thought. I think part of the problem has been there's more of a stigma for men to get help or get treatment, especially for eating disorders, which have been traditionally thought to be a feminine disorder or a female disorder. So in particular, we know that the rates of eating disorders are higher, more at a ratio of 3 to 1 based on the National Comorbidity Survey replication. And also the fact that binge eating disorder has now been included in DSM-5, we know that that's the most common of all eating disorders. And it has a much closer ratio to that of women. It's more like a 60-40 ratio. So men have a lot more binge eating disorder, and I think that the whole emphasis on obesity in our society as a medical problem, but also the idea of food addiction emerging, the fact that binge eating disorder is now a bona fide disorder, and it occurs very frequently in men. I think that's certainly a part of the increased recognition. Whether or not the rates of eating disorders have truly increased in men over the years, it's not really clear whether that's really the case.